can't hear me well or something isn't coming across correctly, just unmute yourself and holler at me because I have an issue trying to keep up with all the participants online. Um, but briefly, the first slide kind of goes over the objectives here. Um, First, we'll go with kind of a brief background on climate change. We won't spend too much time on the basic science, but more just to get kind of the grounding so we're all speaking the same language. Um, Primarily, it's going to focus on identifying areas of health that climate change impacts. And the big thing there is doing it both directly and indirectly. And for this talk specifically, I try to focus on local issues in South Carolina, and then finally discuss the role of the pediatrician uh, outside the clinic. So first, I think it's important to understand kind of how I got here. So I'm a general pediatrician in Lexington, South Carolina, and I've been in private practice for like 10 years. Um, Around COVID, I began having, I think, what everyone did is kind of an existential crisis. So, the components of which was, the crisis of responsibility, what was my role to play in this public health crisis as a general pediatrician. Personally, crisis mortality, which I think we've all been touched by those affected. A crisis of connectedness. So how was I connected to my community and to my friends and to the public health arena, frankly? And then a crisis of meaning. So beyond the role of general pediatrician, what meaning was I missing in my profession and personal life too? Which kind of led to this big question. So when COVID's over, what was my responsibility as a pediatrician, and how do I do the most good and hold the values of pediatrics? And that kind of led me into the public health realm and the search for, well, what is an issue? What is the issue that we're not addressing, that we're missing? And invariably led me to climate change. So this kind of resonated with me is the Lancet Countdown 2017 report, which really enumerated the issue here that for public health, climate change is the greatest threat over the next century. And we'll enumerate some of the reasons why. Importantly, all the gains we made over the past 50 years in public health have a risk to be undermined by the process as well. Humans are the cause of it. And this next point kind of relate or resonate with me as well, that the knowledge and the inaction have jeopardized lives. So the concept of greenhouse effect and global warming isn't new, and it really didn't start in the 80s either, with the congressional report and the Earth on Fire on Time magazine. It was known for decades prior, and the inaction or the politicizing of the issue have directly impacted us currently and will for the next 50 years, as I'll show you. So then specifically for pediatrics, the AAP was actually one of the first professional organizations to include climate change in their action statements. In 2015, you'll see their direct quote, updated in 2018. And I want to point this out because of one of the authors, Dr. Phillips Bourne, is at Emory and also kind of central in the push to make climate change in the education of which part of the ACGME requirements. So this may be something that we hear more and more about during residencies. And then finally, the health initiative, the Climate Change and Children's Health Report, which again has a statement. So it's pretty clear that our professional organization takes this seriously and takes this as a major public health crisis. So now we'll kind of delve a little bit into the science of climate change, kind of a superficial overview just to make sure we're all speaking the same language. The first slide here simply just demonstrates that warming is happening, right? That we can go back, hundreds of years based on analysis and see that the temperature has grossly increased over the past decade since, in the past 100 years, since Industrial Revolution times. So that baseline there is based on the 1960 to 1990 average. And you can see that even based on then, a baseline taken after the Industrial Revolution, we are warmer now than we were at that baseline. To understand why, it's very basic science at this point, but it's the greenhouse gases. And it's a phenomenon that has been well established for hundreds of years, but for some reason still gets debated. The one we're looking at is carbon dioxide. So the other ones, the methane and nitrous oxide, are players. The big reason why we focus more on carbon dioxide is because of the long-term effects we have in the atmosphere. So while methane may have direct and immediate impacts even beyond what carbon dioxide does, the half-life and the term of that forcing is limited. So again, for us, we focus on carbon dioxide. The graph on the right demonstrates again just the steady rise in the parts per million since the 60s with accurate measurements. That fluctuation is just due to flora. So one of the arguments I hear a lot is, how do we know it's human? But what about the natural causes for warming? So I think this graph kind of lays it out, and it's a bit busy, but I'm a very visual person. So over on the right, we have the delineation of what all are the forcings or the impacts on climate, on the warming or cooling of the atmosphere. So the bar, you can see the greenhouse gases at the top. So carbon dioxide by far has the measurement of the highest impact of warming, along with methane and nitrous oxide. And then going down, we'll see some of the other effects. And one I wanted to point out, interestingly, is the aerosols. You'll see at the bottom, which is pollution. So that's smog and dust and debris from manufacturing actually has a net cooling effect. So even taking all that into account, the calculation for what is the solar or what is the total natural effect of warming versus what is a human effect is the summative down there at the bottom of the graph, which you can see even within the confidence interval that human effects are the most impactful on the warming of the atmosphere. This one's really busy, but I included it just to show where these emissions for carbon dioxide are coming from. So again, large part, you can see on the right, the gases. If you flow over to the left, you can kind of follow where those gases are being emitted from. The big thing I just want to point out is that transportation and electricity and heat are by far the most weighted as far as their impact on emissions. And then here kind of breaks it down even further to road emissions, residential, commercial, but showing that we play a role, these areas play a role, these areas play a big role. To address some of the elephant in the room, there really isn't a controversy among really scientists or anyone whether global warming exists or whether that humans are the primary drivers of it. So I just included a couple studies here with a couple of quotes directly from it, but we're talking about 90, 95, 97% consensus that humans are causing global warming, and it's a fact. Feel free, if you want to take the slide or whatever and take these papers out, but if there's any doubt, that's not the debate to be having at this point. The debate to be having is what do we do about it, whether it's adaptation or mitigation, not necessarily the presence. And then finally, just as some more background, this is the projection data from the IPCC on global surface temperatures. So it's busy again, but what I want to point out, one, is what these mean is basically they ran analyses based on emissions, potential emissions, and mitigative and adaptive measures. So the 8.5, RCP 8.5, this red line here, is classically referred to as kind of the business as usual model, which isn't quite true. So the projections for emissions that the RCP 8.5 was on, we've done better actually. So probably, at the top of this graph where you can't see it, likely not there. And on the other side of that coin is the RCP 2.6, which is this low, darker blue, purplish line, which was the projection model where if we did everything possible, so if we reduced emissions substantially, we had all buy-in right at the beginning of the process, what would the impact on warming be there? So this likely is not happening. So we can kind of infer that it won't be as bad or as good as we also can be. So somewhere here in the middle, which you'll see, which is the 6 and 4.5, that those lines almost are superimposed until about 2100 and then start deviating a little bit there. The reason I wanted to point this out is that later on we'll talk about adaptation and mitigation processes, and both are important. Even if we go all in on mitigation and we reduce emissions to 0 in 5 years, which is completely unfathomable, we will still have a net warming over the next 100 years that we still have to adapt to and deal with. So to me, this isn't an either or, this is an and question that needs to be addressed. So just some basic takeaways from that: climate change is happening, it's real, it's human driven. There's no controversy, it's indisputable consensus. It's a real problem, but we can do something about it. So I'd like to take a moment of Zen and take a breather and appreciate this baby giraffe. And then we'll talk about the public health impact of climate change. So this graph is, again, a little busy, but being a visual person, it helps me kind of wrap my mind around all the areas of public health impact that climate change has. So this is from the CDC website. And you can see in the central circle are the measures of climate change, the results, the rising sea levels, extreme weather, rising temperatures. The middle circle have to do with the direct impact. So, rising temperature, increased severe weather, extreme heat, environmental degradation, water and food supply impacts. And on the outside are the sequelae of that based directly on public health. So air pollution having a direct effect on asthma and cardiovascular disease. Changes in vector ecology, which is kind of this controversial somewhat, but gets a lot of attention with the spread of vector-borne diseases in areas not typically seen. Increased allergens, which direct impact on allergies and asthma. Water color, you can see from this graph, there's tons of places where climate change impacts public health that may not be readily apparent, but is present. This is another way to look at it, which helps us, I think, in developed countries and in higher socioeconomic statuses to understand why it's important for us to address these issues, not just here, but also on the context, the social behavior context and institutional context. So the climate drivers, which we all talked about, the exposure pathway, so how do people get exposed to these increased risks, whether it be extreme heat, pollution, and then what role does their social and economic status, what role does the institutional structure play in their exposure, and how does that impact their health outcomes? So these can be really muddied, and it's hard to tease out one thing or the other, but when you look at adaptive methods, again, looking at these different pathways, how can we decrease the exposure? How can we improve adaptability? How can we decrease vulnerability? Should be a keystone of those methods. So for this talk in particular, we're going to look at 3 that focus for South Carolina: extreme heat, severe weather, and briefly on air pollution. Again, vector-borne illnesses, I feel like everyone thinks it's really cool because we're talking about malaria and the history of South Carolina and the disease-spreading vectors. But these are very complicated because we actually done a really good job with public health in vector-borne illnesses. So trying to tease out the overall effects here locally of that will be really difficult. There are really good evidence of, the spread of malaria up a mountainside where the environment's changed, the spread of Lyme disease up north, but particularly for us, it's more these 3 here. So extreme heat. So that busy slide, which again looks at the vulnerabilities and the exposures, which again, I put this in there just to contextualize why this is a complicated issue, right? That we know there's going to be prolonged heat waves. We have a population in us that have exposure to the elevated temperatures, and then the risk factors, right? So city planning on the urban heat island effects, which I'd love to go into more, but essentially in a city, lots of asphalt, lots of concrete, those cities hold on to and are warmer than the areas around there. For us, outdoor work and recreation, these are the student athletes. Heat prevention messaging, that's for us to do. And then for medication use, personal, physical, and cognitive constraints, that's for us to recognize as primary care physicians and make sure we're educating our patients. This graph, I just wanted to drive home the effects of global warming and climate change on extreme heat. So here on both of them are going to be the two major drivers. How hot is it during the day and how cold does it get at night, right? And you can see just comparatively that up through us in the Midlands here, that the number of days over this 95 degree threshold would increase by 75, 60 to 75. Concurrently, warmer nights, which would impact the exposure. So a different way to look at it, this is from Charleston, but in general, you can extrapolate this data to any city that take their baseline in 2000, which for Charleston was 16. Some of the models, you can double, triple, quadruple those number of days of extreme heat exposures to 2050. So again, happening now, important to take adaptive measures now, will be happening 3-4 times for more frequently in the future. So this graph here, any talk with climate change, you may see vulnerability because again, adaptive measures make a difference. And these two graphs comparatively by county, here on the left would be the projected extreme heat future days. And these are kind of these areas, these counties here, which again, near 100 days, right? Superimpose this mentally on this map over here, which was from the CDC, where they take measures for social vulnerability, run it through an algorithm and get a numerical value. So the closer you are to 1, the higher risk you are. And you can see the counties that have the least protection against exposures are the ones that we'll have the most of in the future. This graph isn't pertinent here. It's from the Chicago heat wave in 1995, but I wanted to drive home the actual mortality of it, right? That extreme heat is under-recognized in the United States and in South Carolina in particular, but has a significant impact on mortality. And this was kind of a very clear delineation of that in Chicago here, where you'll see the heat wave, the lag effect, and then the daily death totals spiking, several days after the exposure. To personalize this, I included this story. So this is Zachary. He was a high school football player in Fort Myers, Florida, an area that intuitively you would believe will be well equipped and educated on extreme heat exposure. At the end of a practice, mom got a knock on the car window telling her son couldn't get up on his feet. They were carried in his coach's arms. He was making noises. They poured water in his mouth, said he was overheated, called 911. 10 days later, passed away. And this happened the next year and the year after in Florida as well, which doesn't need to happen. So this is where it relates directly to us as primary care physicians and pediatricians, that we need to recognize who's at the highest risk within our population, which for heat-related illnesses in young athletes, it would be football players who have the highest risk for heat-related illness and preseason. So these are the talks that we have when we're filling out the sports physical forms in the spring for upcoming conditioning in the fall. And there's tons of reasons for it. higher temperatures, lower conditioning, which we can go through more at a future time. Here, it kind of drives home the point again that even though these deaths are not frequent in the global sense, they occur in their individuals, and that every one of these are preventable with the appropriate education and resources available for schools, right? So the big push from the Florida case was to have cold water immersion tubs at practices, and that's still going on. That was just recently established here in South Carolina. But again, a lot of the measurements and a lot of the resources fall to the schools. And as present from the other graph, you can see that the areas that have the highest social vulnerability relating directly to economics are also the areas that have the highest extreme exposure and are less apt to be able to afford the measures that we can afford in more fortunate counties. The other part I wanted to drive home here is this bottom part. So I think the inclination when we fill out these sports physical forms is to leave off some of this information about medications, but speaking to athletic trainers in the area, that's important that they are aware if there's athletic trainers on site of the increased risk for heat illness in certain individuals. So they keep an eye on them, right? That if they're on stimulants, if they're on ADHD medications, you don't have to be openly discussing how much and what we're doing, but just relaying that they are on medications that put them at increased risk for heat-related illnesses will alert the athletic trainers to keep a closer eye on those individuals. So again, let's take a second, admire this baby pig, and then we'll move on to something heady again, to severe weather. So busy again, but want to drop home the point that when we talk about the health outcomes, we're talking about climate drivers, we can't ignore the social, behavioral, and institutional context. Here, and this is something we've done a bad job with in South Carolina, is development in vulnerable coastal areas or floodplains, flood control, which is a whole other conversation for Charleston. The infrastructure for transportation, communication, healthcare, access to, over here, the individual social determinants of health, storm preparation, occupation, who can actually evacuate an area, who cannot, who's making those choices, and how can we support them. This graph I wanted to include just to demonstrate a kind of a fallacy and also the facts. So a lot of times we have a bad hurricane season like this past one, and then we look at named storms. We have a bunch of named storms, and the go-to is that's because of climate change, which that part has not been evidenced, right? That it's a bridge too far to say that the number of storms are directly related to climate change. It's also a bridge too far to say individual weather events are related to climate change, right? So we'll go through some of the more recent hurricanes and flooding here in the area soon. But I want to be clear that I can't say that each individual weather event is directly attributable to climate change. However, what is evidence is that the frequency of the severe weather is increasing, right? So the number of hurricanes may not be increasing, but the number of categories 4 and 5s are. The number of flooding events directly related to the days of increased precipitation are increasing. So this graph will look at the direct and indirect causes of morbidity and mortality related to hurricanes. And I include this to show with severe weather just how widespread the effects are and how narrow we sometimes look at it. So the direct effects, I think we see clearly, right? So storm surge, precipitation, and winds, which will then impact all of these areas here. So secondary hazards, power outages, evacuation, displacements, residential destruction, exposure to the flood waters, living in a flood damaged home, drinking flood contaminated water, and then the sequelae from that, right? So GI illnesses, respiratory conditions from the homes, skin and wound infections, mental health effects is a huge one that is underappreciated, underfunded, and forgotten about many times. Infectious disease, particularly in shelters, interruption for care for chronic illnesses, and recognition for acute processes. Injuries are a big one for cleanup. And also over here, the carbon monoxide poisoning, one of the biggest causes for mortality after a severe weather event is inappropriate use for generators, which we should be able to relate to individuals, right? That should be part of our communication process. Instead of ending at evacuate and clean up, we need to make sure they're aware of how to do so safely. So information about the two more recent hurricanes here that impacted South Carolina, Hurricane Florence and Hurricane Matthew. I want to include the slide, one, to demonstrate, even though, retrospectively, we forget about this sometimes, these were major events at the time. Particularly Hurricane Florence, 80 shelters open, 8,000 people use the shelters, almost 200,000 had power outages, 130 water rescues. Again, Hurricane Matthew, these individuals, two died direct from floodwaters, which didn't have to happen. Again, just to drive from the point of social vulnerability, this graph here, or this map on the left, after Hurricane Florence, 96 hours, average occurrence interval for the amount of precipitation. So these graphs are always kind of odd when you look at 100-year flood or 1,000 years flood, but without getting too far into the data on that, basically it flooded and rained a lot here, and superimposed over here on the social vulnerability of South Carolinians from the DHEC site shows that these are the areas that can least afford to be impacted by these floods and severe weather, and these are the areas that are getting impacted more frequently. These are the missed mortalities, right? That the chart over here from this article discussed the direct death toll from Florence, right? So the ones from drowning, from blunt force trauma, from the hurricane itself. The darker blue are the indirect causes. This is the ones that many times are forgotten about, right? The over here on the right side are their individual stories, right? That I think it's important to remember that these numbers have faces and people associated with them. So 44-year-old mother of two had an aneurysm. 85-year-old who fell into a coma on a 13-hour car ride. A former retired high school teacher who died asleep in a shelter. A mother of two who overdosed at a shelter. So all of these people's health were impacted indirectly by the hurricane. With these deaths have occurred with or without the hurricane. Again, it's hard to tease out one or the other, which is why they kind of fall out of the reporting. But I think it would just be naive to believe that it didn't impact these people's lives. And then locally, the flooding in 2015. So I don't know if you guys were around or the residents were around during this time frame, but it was a major event here. Busy slide. I'll for the sake of time kind of gloss over this, but basically this was an extreme weather event that was kind of a culmination of several fronts and hurricanes, and kind of all came together at just the right time to dump a massive amount of rain at one period of time. Again, the health impacts of the flood are underappreciated. I still believe that the Red Cross delivered 150,000 meals, provided 7,000 mental health services. And for those in the community and dealt with, mental health services, they may have provided them, but the follow-up is not there. And us recognizing individuals still whose lives were impacted by the flood, whose parents lost their jobs or their homes are damaged, they still have trouble accessing mental health. In the hospital, I'm sure you guys remember, but there was direct issues there. And 7 died directly from drowning. And one of those I want to just, again, I think it's important to have names and faces with these numbers that we throw out there, is Alex Holmes, died right down the street on Sunset Boulevard after leaving the hospital, the ER, with abdominal pain. Her car was trapped in floodwater. The electrical system malfunctioned. She was unable to get out and passed away. And finally, the impact on delivering a healthcare. I included this in Charleston because that's where I studied, but also, and I think the amount of flooding they're having there is just at times unfathomable. Here, this is just nuisance flooding. So you catch the tide at the right time and have the right normal rainfall. These are the areas with normal flooding. This graph, and you can see these red lines and orange arrows, these are the pathways to access emergency care, which clearly are directly impacted by the flooding. Just to handle this, there has been millions and projected billion-dollar adaptation methods to try to alleviate some of this. Now, the next slide, again, a 10-foot storm surge, right? That access to care, hopefully these people could evacuate, but even if they couldn't, due to socioeconomic status, there are areas where there is no access to care. And these are adaptive measures that we need to be aware of and start to discuss. So for us, I think the issue here should be this bottom one, right? That we need to, in our practices and in our hospital systems, which I feel like we do a really good job on the direct measures with the hospital association for planning for emergency plans. It's the indirect, I think, that gets lost a lot. The follow-up. How do we plug these people into healthcare when they're displaced? How do we follow up with the mental health care? Anxiety can last for years after a major event. Is there follow-up for individuals impacted by severe weather? And how do we do so? So for the sake of time, I'm going to go over briefly the air quality, which is more of a co-benefit from climate change action, since, as we remember from the other graph, that air pollution actually has a cooling effect, but it has a very massive effect on public health, where, I mean, this number is staggering to me, and this isn't local, if you take it what it is, but 4.2 million premature deaths linked to ambient air pollution. That's a staggering number, right? Of course, the majority from respiratory, but I think it's important to note that these aren't just respiratory issues, that these are systemic illnesses exacerbated by air pollution, which here is our takeaway, that maternal exposure to ambient air pollution associated with low birth weight, preterm birth, and small gestational age births, which were proven in a study from North Carolina. In the bottom part, affecting diabetes and neurological development in children. This one specifically talks about ozone, which again, I'm going, for the sake of time, kind of move forth, but as you can see, has a varying impact on public health. I want to hit this up because this is a terminology that we hear a lot, discussing particle size and what it actually means. So this little graph, or this illustration, demonstrates just what, when we talk about PM 2.5, PM10, what does that actually mean? And this gives you an idea of the size, I think. And I think this helps contextualize why inhalation of PM 2.5 goes beyond just the respiratory tract. These are small enough to cross that barrier and impact cardiovascular health as well. And beyond that, so briefly, 4 quick studies here that looked at exposure for PM 2.5 and found in all these that the exposure increases risk for childhood asthma, allergies, and even sensitization to food allergies as well. Allergy season is increasing, right? So pollen is increasing pollen load. For us in South Carolina, that may be longer and more intense. For areas of the Midwest and Canada, there will be a substantial change in the flora. So this is a study that gets a lot of attention about ragweed pollen increasing. Again, not local, but I think important to note that this is a substantial issue. All right, so this is kind of what I want to take away. So all that, and there's even more to kind of go into. I just want to scratch the surface of major public health impacts of climate change locally. But I think the best way for me, at least, to contextualize this is that it's a threat multiplier, right? That we are aware of intrinsic issues in our healthcare system that pose individuals at increased risk. And the effects of climate change only exacerbates those discrepancies. And it's our role as a primary care provider to advocate for our patients and our future patients. So the 2050 and 2100 children who we may not directly care for, still we are their voice at the table, and we have a moral, I believe, but also professional duty to advocate for them. So what does that mean? So how to engage with climate change as a primary care physician. The two terminologies that get thrown around: mitigation, adaptation. Mitigation is simply you lessen the amount of emissions, either by reducing the emissions or by capturing with future technologies. I think for us and for locally, adaptation is where primary care physicians should focus here on the individual basis, is that we can help our patients and our communities better prepare for already existing changes of climate change, right? That these adaptation measures aren't predicated on beliefs in the RCP 8.5 models or the worst case scenarios or alarmists. These are issues that we are currently seeing that are only going to be exacerbated and multiplied by climate change. So this kind of goes into, I want to talk about this briefly, individual level mitigation. There's various reasons why this is important. And these are some of the efforts that we can make on an individual level to help with emissions, right? So personal transportation, electrical vehicles, a plant-based diet, or this hippie who's taking my hamburger, which is more so for beef production than methane release, but whatever. Solar energy for homes, reuse or recycle. The recycle is just doesn't happen as frequently or efficiently or cost effectively as one is led to believe by plastics. And compost is, if you're into it. I'm not going to play this video, but what I want to show is to avoid personal guilt if these mitigation measures are beyond you, right? So Vi, which is the app I was showing, is a product of Launchpad, which is a venture capital group funded by BP, who simply hands out money to these low carbon startups, hoping to make money off them long term. The whole idea of carbon footprint has been appropriated by oil and gas companies as a PR campaign to make this a you problem instead of a system and them problem, right? Looking at emissions from COVID, we have 3 to 7% reduction, which is awesome. However, that has to be replicated and doubled, and then doubled again to reach the desired level of reduction, which is just not feasible, right? That personal measures of mitigation is important, and it's important to model, to take responsibility, to open a conversation, but it's not a point to feel guilt or anxiety over. More importantly for mitigation is advocacy, right? And that's where organizations play a big role. That's the Medical Students for a Sustainable Future. That's the AAP. That's the Conservation Voters for South Carolina. That's South Carolina Health Professionals for Climate Action, which this is where I plug my organization. Go to the website and read up on it. But these groups have the voice and have more power to advocate on a policy level for mitigation. In practice, it's adaptation, right? So we, as primary care physicians, need to plan for early and longer allergy seasons, right? That, having individuals come off their allergy medications when they historically used to may not be the right answer, right? We need to be more mindful for screening and monitoring for mental health effects after extreme events. Not how they're doing immediately after, but how they're doing 6 months to a year afterwards. We have an obligation to inform and educate our parents, our school systems, and our student athletes on heat exposure, heat exhaustion, and the appropriate measurements for extreme heat, which is wet bulb, globe temperature. In office, we need to do a better job for disaster preparations, right? That we need to recognize there are vulnerable populations who may not be able to access healthcare during flooding, during extreme weather, during extreme heat, that we need to work on how do we reach out to those individuals. Is it utilization of telehealth? Is it centralized databases and phone calls? And then in office, how do you effectively run your office during one of those time frames, right? So personally, from the flooding experience, that our office was short staffed, and we had to weigh office safety versus access to care, and then furthermore access to imaging, access to labs. How do you work through some of these issues? For us having a conversation with patients, if you want to take it one step beyond, is hyperfixating and believe on the co-benefits. So not necessarily berating them for not having an electric vehicle, but discussing the health benefits of a plant-based diet, or the cardiovascular benefits of biking or walking. And then not to absolve us for responsibility. Hospitals and hospital systems are a huge waste producer, and we need to start having that conversation of how to impact our organizations, whether it's mine or y'all's, for sustainability and quote unquote greening of where we work and where we play. All right, so that was a lot. I want to make sure I had time for questions if there's anything. I'll give you guys a second. My email's down there. If anything kind of came up that you had questions about later and you couldn't think of the question at the time frame, feel free to email me. Let's see if there's anything. I don't see anything in the chat. So if you guys got any questions, feel free to unmute yourself and go for it.
So, Dr. Emery, that was amazing, man. That was real eye-opening, I think, hopefully for a lot of people. I had just one quick question, I guess, is, I think sometimes getting started is the hardest part for a lot of people. Like they walk away from this kind of lecture, this kind of topic, and they're like, yeah, let's go, let's change things, let's make a difference, but they don't know where to start. So like for residents in particular, is there a place that you guys as an office, or that you in particular think would be a good place for them to start the process of not just impacting their patients, but also how they can impact health systems and that sort of thing? Any ideas about that? I know it's a real loaded question, but
No, there's a couple of methods. So one is getting involved with organizations, right? That the heavy lifting has already been done for us by the medical consortium, by South Carolina health professionals, by the AAP, on the advocacy part of it, right? So that's why I didn't want to have individuals take on this huge burden of how to address climate change, where it's more so about being aware of the impacts on public health, being aware of something we need to start being cognizant of in our daily practice, but also not taking on that huge burden, right? That there's places that we can come together as a community to help with that voice, right? On the individual basis, to me, we are already doing a lot of the adaptation without being aware of it. So yeah, I go back to extreme heat, but I think that's something that really kind of resonated with me. If I got a second to tell a story. So my oldest kid is 11, he plays soccer, and it was like July, he's played for like 8 years, and I get a call from his coach that, recent feeling that great, to come to the field and pick him up. And it's like a mile from my office, and it's right at the start of COVID. So my first thought was, oh God, the pediatrician's kid has just given the entire facility COVID. They're going to ostracize me. My kid's kicked off. This is it. And I get there, and he's sitting on the sideline and just looks awful. And his coach comes up to me and says, yeah, I think he got a little overheated. He just sat out and couldn't come back into play. I thought maybe we should come pick him up. I was like, all right. And then talking to him, he was telling me the story that was really horrified me, that, he was playing, he got lightheaded, he wanted to power through it. He started having a headache. He started powering through that. He couldn't hear his coach because he started being lightheaded. He could barely walk to the sideline. He urinated on himself. He couldn't get up, and no one recognized it, right? And his coach is a varsity high school coach who didn't recognize the signs of it. I, as a pediatrician, didn't jump there because we live in South Carolina. He played all the time. Like, he's not at risk, right? But so I think taking that is, when we have the patients in here, recognizing that extreme heat is a problem, to address that with the patients, right? Just to educate. just to have them be aware. If, you had that patient in your office that was a refugee from Katrina or from Puerto Rico, recognize that your conversation doesn't end there, that, hey, maybe I should, when they come back for their checkup, ask them a little bit more how they're doing, how they adjusted, anxiety, depression, being more aware of these situations. I think it will be helpful instead of taking that burden on how to fix climate change. How do we as pediatricians adapt to it?
And you couldn't have picked a more timely time to have this discussion with all the winter weather that's going on in Texas and
Yeah.
up in the Midwest right now. It's certainly going to be something that even right now is going to be impacting people. So, all right. Anybody else have any questions for Dr. Emery?
This is a very light-hearted comment, but I really appreciated all the animal photos throughout your talk.
Oh, thanks, man. I need a moment of zen when I do these heady things. You get kind of wrapped up in it. I think it's best to take a breathe. Like kind of like what Scott was saying, that there's a lot of anxiety around this, and the easiest thing I think when we have that is just to kind of shut off and take that moment to take a breath, and yeah, it helps. Cool, guys. Well, I guess if there's anything else, just shoot me an email or let Scott know. And then again, the best thing to do if you're interested in hearing more or learning more about it, hit up the websites, the South Carolina Health Professionals Climate Action or the Medical Consortium. There's a wealth of information out there, and hopefully we'll do some follow-ups again in the future.
Thank you so much for doing this again, Dr. Emery. We appreciate you.
No worries, guys. Y'all have a good one now.